Good morning, everyone. I'd also like to thank the organizing committee for the opportunity to share a few ideas with you this morning. They've asked me to share with you some of the research that we've been doing using live cell therapy to regenerate soft tissues. As Sam just talked about, I'm absolutely convinced that in the future we're not going to be doing anything passive. All of our surgeries will have an active component to it. And as you've seen this morning, there's lots of neat things that are going to allow us to achieve things that we've just dreamed about in the past. If you look at what's going to provide these active components, it's probably going to be one form or another of tissue engineering. And I think it's appropriate for me to disclose that I am going to share with you information that is funded by a number of different companies, but I always maintain complete control of the data and reporting of everything. Up to this point this morning, we have heard about tissue engineering using bioactive molecules. I like to think of the tissue engineering matrix as having on one end bioactive molecules and on the other end live cells. And I'm going to limit my conversation this morning just to the live cell end. Now, as you begin to think about implanting live cells into the human body, to me, the exciting thing about this is you need to kind of switch gears and not think of this like a tissue replacement graft. This is not a dead piece of tissue or even a piece of palatal tissue that we're placing in there. You need to think of it more like a dynamic cellular delivery system. It's providing cells, it's providing cytokines, growth factors, all sorts of things that are important for angiogenesis and that will stimulate regeneration. And to me, the most important thing it's providing is it's able to deliver it on demand. If you've paid attention to this morning's programs, you heard a lot of things about, well, we really don't know the right concentration. One of the big problems is, as powerful as these bioactive molecules are, is that how do you know you really got it to the site? And if you got it to the site, did it last long enough? Maybe you have too much, maybe you don't have enough. Well, theoretically, with live cell technology, these cells are talking to each other. And they're talking to the cells down in the defect, and they can physiologically titrate the amount of these bioactive molecules that you need to regenerate. The first one that we used was a living human fibroblast-derived dermal substitute. It was simply a dermis, and you see here human fibroblasts lying in parallel. This is about at 4 days, and these fibroblasts come from neonatal foreskins. It's nice to have a single-cell donor line because it affords you great ability for testing, great uniformity of the cells, and also the ability to harvest lots of these kind of things. Now, the fibroblasts are, in this particular material, are seeded onto a vicryl mesh, and you're seeing here at about 3 days the fibroblasts stretching across the vicryl mesh. And if you were to revisit this at around a week, you wouldn't even see the little spaces in the vicryl here. As you know, the vicryl is lost through hydrolysis, so you implant this into the bed, and the vicryl is lost. I like to think of it as a little factory you're placing in there, and it's going to produce glycosaminoglycans, collagens, all sorts of growth factors that stimulate the angiogenic and the inflammatory pathways and help with the healing process. And for those of you that are interested, we published 2 studies using this in Journal of Periodontology in 2005. And I bring this up really just to set the stage for the next generation of material that we recently have completed the pilot study on, and we'll be publishing this paper soon. It's a study in which we're looking at using it compared to the gold standard free gingival graft in an effort to generate keratinized tissue. When you look at this material, you immediately see it looks very different than the first generation material I showed you. It has a fully differentiated dermis, but it also has an epidermis as well. One of the interesting things that we see when you have this kind of material as opposed to the one I just showed you is there's quite a bit of synergy or crosstalk between the keratinocytes and the fibroblasts when they're present together. That in other words, you get more cytokine production when you have both of these together than when you have them separately, and it mirrors what you have in skin. Also, when you look at the type of cytokines that are being produced by this material, note that you're going to see some that we already know are very important in periodontal regeneration. We've got BMPs, we've got PDGF, VEGF. All of these are growth factors, cytokines that we already recognize that are important in periodontics. Along with the cells, it also has extracellular matrix components that are going to be important: collagens, fibronectins, tenasins, inhibitors of MMPs. And if you look at the cross-section between the material and skin, you see the comparison. Now, originally, this material was made as a tissue replacement graft for skin. So if you're going to replace skin, it makes sense to make it look like skin, right? Well, it's not really the anatomical appearance that's important. It's the fact that you actually have the fibroblasts and the keratinocytes together. But if you look, it has the same cells, except it doesn't have Langerhans cells, melanocytes, lymphocytes, endothelial cells, red blood cells, things that would cause an inflammatory response. And it also doesn't have sweat glands and hair follicles, other things you might not want in the oral cavity. It also produces a great deal of VEGF. Now, as clinicians, what do you and I butt our heads up against the wall every day? Why can't we predictably regenerate class bifurcations or regrow papillas? To a great degree, it's because of blood supply. When we use surgical guidelines to tell us what we can and cannot accomplish, most of those guidelines are based on blood supply. Well, what if we could go in and grow our own blood vessels into these areas? You know, it has the potential to really rewrite the rules of regeneration. They've taken this material, infarcted hearts in animals, placed the material on the infarcts and get spontaneous blood growth around the infarcts. So it has great potential to change the way that we've done things in the past. Also interesting to me that it produces a peptide called beta-defensin on an ongoing basis. Now, if you cut your finger leaving the room, one of the things your body does is produce just a short burst of beta-defensin, and it's an antibacterial, antimicrobial kind of thing, but it just happens on a short burst. Well, what's one of the problems with regeneration in the oral cavity? It's the bacterial bioburden that we have. Or if you saw my inflammation lecture yesterday, we were talking about the importance of controlling inflammation as it relates to regeneration. Well, this material produces beta-defensin on an ongoing basis. So potentially it can reduce the bioburden and perhaps be important in the regeneration of the tissue that you're working with. A very interesting slide here that shows that the production of these cytokines are actually more robust at 4 days after application than they were when you initially placed it into the defect. Again, this speaks to the fact that this is a living tissue that's interacting and reacting with its environment. You know, and it's asking, well, okay, the body's saying, well, I need this. Well, okay, here comes that. Okay, you got enough. Well, we'll shut down that. So this is not a passive material. And as proof that it is a living material, here the material is where it's been wounded at 0 hours. At 12 hours, you can see the keratinocytes beginning to migrate over it. By 24 hours, the keratinocytes have completely covered it. And by 5 days, you have a fully differentiated epidermis. In the pilot study, we wounded the material to upregulate the production of cytokines, and I asked, you know, when I was a little more naive about the material, why couldn't you do that in the lab before you send it to us? And the answer is because it'll heal itself before you get to it. So it's kind of science fiction-y stuff, but this is what we're going to be dealing with in the future. With our study, this was a 20-patient study. We had 7 patients that we took biopsies to look both at histology and persistence. In blinded histologic evaluation, the histologist could not tell the difference between the free gingival graft and the test graft, just good differentiated connective tissue and keratinized epithelium. And when we did persistence, we found no evidence of persistence at 6 months with this material at all. It has a very safe profile. It's been used over 200,000 patients. This has already been used on with no safety issues to speak of whatsoever. We're using this material in a Z-fold. We found in our first study, we're using the dermal replacement graft that we got less shrinkage if we had more layers. And again, this gets back to the way we used to think than to the way we think now. When I first began this process, I was thinking of doing this Z-fold because it gives it a thickness. This is the material as it looks after it's had the Z-fold, because it gives the thickness as to what you would assume that a free gingival graft would look. But you got to divorce yourself from that. Actually, what we're doing with this Z-fold is we're increasing the dose of the material. So we're increasing the amount of cells, the amount of cytokines, all the things we're wanting to deliver by doing the extra layers. Now, of course, this is what we're trying to avoid. All of us would love to have an unlimited amount of tissue that we can go in and graft, and also to reduce the morbidity of our patients. In this study, we standardized the width of the grafts. This is my free autogenous graft. So the width of the free autogenous graft and the test material were standardized at 5 millimeters. We'll just show you one of the cases. This is the test graft and the free gingival graft here. And at 1 month with the test graft, you can already see the mucogingival junction beginning to form, a nice broad zone of keratinized tissue that's mimicking pretty much what we're getting with the free gingival graft. If you follow that out to 6 months, this is a 6-month panel, a little closer up at 6 months. 6 months stained with Schiller's iodine to differentiate the mucosa from the gingiva. And we looked at all of these different parameters. We looked at width of keratinized tissue, probing depth, recession, clinical attachment level, inflammation, healing time, change in color, change in texture, resistance to muscle pull, and subject preference. And when we compared that to the free gingival graft, the only significant differences we had were these parameters, and I'll discuss each one of those. If we look at width of keratinized tissue, our pilot showed that the amount of keratinized tissue generated with the free gingival graft was greater than the test graft, 4.5 versus 2.4, but we found that the test graft was safe and capable of generating de novo keratinized tissue up to 4 millimeters without a donor site. Now, I think that's pretty spectacular that you can generate 4 millimeters of keratinized tissue without a donor site. 24 out of 25 tests demonstrated an increase in keratinized tissue, and a full 3/4 of the sites yielded 2 millimeters or more, 2 millimeters or wider bands of keratinized tissue. Again, to give you a flavor of what we were doing here, the test graft, the free gingival graft, this is at 3 months, a 3-month stained with the Schiller iodine stain, and this is at 6 months. And if we blow this up, you can see this is our test graft and this is the free gingival graft. Both yielded very nice zones of keratinized tissue. You can see both are resisting muscle pull, but note that this has a much more aesthetic look. I think, we know today from our guidelines what we can and what we cannot do as far as grafting. I think our next step is to make certain that our end result is indistinguishable from what Mother Nature intended for it to be there. And with this kind of graft, we're going to come closer to doing that, because what's happening here is it's stimulating de novo regeneration of the patient's tissue. This does not function like a graft in the way we typically think of it. The reason why up here, this is a nice functional palatal graft, but the reason this looks like this is because these cells come from the palate. This is palatal phenotype, where these cells come from the adjacent tissue. So these are cells that belong there. And so when we looked at these two parameters, change in color and texture, the test graft came out statistically significantly improved. And the other significant difference was subject preference. And you can tell me which you'd rather have. Would you like this, or you want your tissue taken to the bioreactor there? We have now begun a multi-center trial. It just started 2 or 3 weeks ago. These are the centers that are going to be doing the next trial. We've already done the first 5 surgeries in our office, and the other centers are about to start. The last study I want to mention is one that we published in Journal of Periodontology this year. So it's, again, a fairly new study. One of the problems all of us have had is trying to regenerate papilla. We've not been successful in doing that with traditional periodontal plastic surgery. We looked here at using a novel approach to use patients' autologous fibroblasts to do that. We take a small biopsy from the palate. The biopsy is then sent to the laboratory. The cells are separated, and the fibroblasts are grown out to a concentration of about 200 million cells per ml, placed in an injectable medium. The medium then allows us to inject these cells into the deficient papilla, expanding the papilla. Now, we're not injecting collagen here. So this is not a filler. Again, this is a dynamic cellular delivery device that has the potential to not only maintain the results, but perhaps even improve over time, since you have the living cells here. We're learning lots more about these gingival fibroblasts. I mean, I used to think in my earlier days these are mundane cells that just sit around and just produce collagen. They, of course, are very important for cell proliferation, extracellular matrix production, growth factor production, cytokine production, produce, again, a whole host of cytokines, and they have a great deal of phenotypic heterogeneity. You can get more undifferentiated mesenchymal cells from human gingiva than you can any other tissue in the body. So theoretically, if you can stimulate these cells in the direction we want them to be in, you actually could achieve real regeneration with this. In our pilot study, we had 20 patients, 118 total sites, but we had 40 matched randomized and test and control sites. Our primary endpoint was change from baseline in the papillary height to the base of the contact. We measured it with a periodontal probe. We measured it off models with a digital caliper, and we measured it through photographic analysis of our digital photographs. We also had secondary endpoints because I wanted to see if we were having any bony changes, both from safety and also to see whether or not we were changing the bone height. So we were measuring that also from the contact point to the alveolar crest and the tip of the papilla to the alveolar crest. And we took radiographs primarily for safety reasons. Now, we took our biopsies here from the palate. The small biopsy was then placed in the vial. It was sent to the laboratory, and it takes about 2 weeks to get a cell line and about a month or 6 weeks, depending on how rapidly the patient's cells grow, to end up with enough cells, the cell concentration to be able to inject. This is how it looks. Again, this is not collagen. This is about 99.6% pure fibroblasts, living fibroblasts that are in this. Oops, going the wrong direction. And so here we have the magic solution. Now, all of the dentists in the audience know that how are you going to inject that in the papilla? This material primarily was used initially for smile lines, that type of thing in the face. It's reasonable to think you might be able to expand the facial wrinkles and that kind of thing, but we all know that you cannot hardly inject any local anesthetic into a papilla, so what makes me think I'm going to be able to inject fibroblasts into a papilla? Well, of course, we knew that wasn't going to be possible, so we devised what we call the Papilla Priming procedure. It's just a controlled surgical insult where I go in, create these little incisions here into the papilla, and it causes swelling over time. And if we look here, you can see at 3 days it's swollen. At 7 days it remains swollen but is not as acute looking, and by 21 days is back to where it was. Well, how can we, and also from the wound healing side, there's some important things going on too, because by going in here and doing this wound, we're stimulating the body's own ability to start producing fibroblasts, and then we're going to leverage that over time. We come in, we inject at around 5 to 7 days after the papilla priming procedure. And I chose the 7-day point because if you look at wound healing, you're moving from the inflammatory phase into the granulation tissue formation phase. And what's happening at about 5 to 7 days, you can see the papilla blanching here as I'm injecting into it. What's happening at about the 5 to 7 days is the body is shutting down its own production of fibroblasts. Collagen accumulation begins to wane. Now it's time for us to hit it again. So in this situation, we were either injecting 20 million cells per ml or the placebo, and I find that I can get around 6 to 8 million cells into one papilla there. It's commonly done in tissue engineering studies to dose this, so we chose to, in order to try to get as many cells as we could, every 7 days we went in and we re-injected. And just to give you an idea on a couple cases on what we found, this panel is day 1, and this is at 4 months using a way to measure distance off of our standardized photographs. And this is papilla priming, first treatment, second treatment, third treatment, 2, 3, and 4 months. It's easier to see on a graph. Here is the initial papilla priming. Now this is open interproximal space to closed interproximal space. Note how from the papilla priming we get swelling, so the space is closing from our swelling. We haven't injected anything yet. Now we do our first injection, a week later our second injection, a week later our third injection. What I want to draw your attention to is that we don't perform any more injections, but I want you to see how this space closes. Theoretically, the reason that space is closing is because we have living fibroblasts that are setting in the tissue. They incorporate into the normal dermal architecture, and they're producing collagen. They're stimulating native cells to produce collagen. It thickens the dermis. So our conclusions from this pilot were autologous fibroblasts are safe and may be efficacious for the treatment of open and proximal spaces. Investigators and subjects' VAS assessment of test sites were superior to placebo. Objective endpoints, however, failed to demonstrate statistical significance, and further studies were needed with more appropriate power and more sensitive measurement techniques. The bottom line on the study was that we had blinded patients and blinded investigators. Both the patients and the investigators felt that they were seeing statistically significant improvement, but our objective measurements didn't correlate with that. I think the problem with that was that we couldn't measure it. Now we have just completed another small little pilot where we now have a photographic jig that allows us to take very precise photographs so that we'll be able to measure changes in the future much better than we've been able to do in the past, and hopefully now our objective measurements will correlate. And just to draw your attention to this will be the last clinical photograph. Again, you can do anything with computers, but this is not computer altered. This is simply going to be a time lapse of one of our patients over 4 months, so I draw your attention to the open and proximal space. So we know it's possible. The next step is to determine whether or not it's predictable. We're actually having conversations at this meeting about possibly moving into a multi-center trial. And in the future, it's my hope, and I'm absolutely positive it's going to happen, that we're going to have ways that allow us to regenerate tissue that's going to expand our scope of practice, but more importantly, going to provide techniques for our patients that are less, less invasive, more robust, and more predictable. Thank you very much for your attention.